First of all, I would like to thank the organizing committee and our chair to invite me to this wonderful meeting. I think this is my great honor to be here. I think in the year of 1984, Taiwan is a hyper-endemic area for hepatitis B infections. And because of all of the social economic factors available and also the disease burden, we were becoming the first countries in the world to launch the universal vaccination against the hepatitis B in the world. You can see from the slide that the hepatitis B is very important in Taiwan because we have about 15% of the adult population, they are the carriers, and hepatoma cirrhosis are very important disease. And 70 to 80% of the hepatoma actually are caused by the hepatitis B. So we start our universal vaccination program right now. And I think each country has its own vaccination programs. They are a little bit different from each other. Here I raised the example of the Taiwan and Singapore. We screen the pregnant women, pregnant mothers, and to give the HB to the babies who were born to the E-antigen positive mothers, but not the E-antigen negative mothers, even though they are surface antigen positive. I think the merit of this, of course, we give the birth dose of HB and the birth dose of vaccines. The merit of this program is that the vaccine efficacy is proven and save the cost on HB. But you have to screen the mothers with HBsAg. If they are positive, you need to further detect the E-antigen. In other countries like the United States, Korea, or Argentina, they just do the very simple screening for the mothers that they detect the surface antigen. If the surface antigen positive, the babies were given HB plus the birth dose of vaccines. So this is one simple and inexpensive blood test for the mothers. And it also have a proven efficacy, but relatively they need more HB for the babies. And in some other countries like Vietnam, Thailand, maybe partial Pakistan, they don't screen the mothers and they just give the universal vaccination for the babies. The merit of this program is that there is no HB use, and very simple, very inexpensive, cost-effective. But a certain failure rate can be expected. In the next few slides, I would like to tell you the results of the universal vaccination. Here is data from Taiwan. The surface antigen prevalence declined from 9.8% to 0.6% in the children and young adults in Taipei City. This is from 1984, actually to 2014. You can see that this is right before the implementation of universal vaccination. Carrier rate is about 10%. And 30 years later, the carrier rate is decreased to about 0.5%. It's very similar to the data given by Professor Jia just now and the data given by the Chinese ministry this morning. And our coverage rate is about 97%. Okay, here is the epidemiology chronic hepatitis B in children before and after universal infant immunization programs. You can see that we use different countries, use different kind of programs, but all of them get good results. I think all the program, the detail of the programs can be modified and can depend on the socio-economic situation and the epidemiological and disease burden condition of each different country. I think that you should make a policy which fit your countries best. On the other hand, for the acute hepatitis B, sorry for some Chinese characters, but I would like to tell you that in the year of 2001 to 2005, you can see that's about 20 years after the launch of our universal vaccination programs. You can see that for the population above about 20 years old, they are not covered by the universal vaccination. They have a high peak of the incidence of acute hepatitis B. This is our most recent data you can see that it's also the peak falls on the population about 30 years old. But this is very different. The incidence here is about 100,000, about 6 per 100,000. Here is less than about 1. So you can see that the acute hepatitis, if the population is under vaccination coverage, the incidence decreased from 6 to 1 per 100,000. For the HBV-related hepatoma, it's the same results. Professor Mei-Hui Chen demonstrated that the population for the birth cohort who were born after 1984, they have a very, very low incidence of hepatoma after the implementation of hepatitis B vaccination. I think recently published in PLOS ONE, there's a paper from China. They also they compare the population. One is under the coverage of the vaccination, the other is not, but in the same birth cohort. It's a little bit different from our data. Our data is use the historical control. And this paper from China, in the same time, they have some patients under the vaccination, the others are not. And they also demonstrate that they are quite different. If the patient birth cohort is under vaccination, the incidence of hepatoma is very low. So the vaccination rate in Taiwan is actually about 97 to 98. It's the same as Gambia. We have for the 3 dose, we have about 97, and for the 2 dose is 98. And if we combine the hepatitis B together with the other vaccines, it's also get a very good results. Here is the results from a questionnaire. I'm a pediatrician. We have an international pediatric hepatology group to study the vaccination conditions in the Western Pacific region, especially in Asia. We also want to do that globally. And up to now, the data shows that like Hong Kong, Korea, Singapore, the coverage rate is more than 97. And HB, mother screen, they are free of charge. But each country have different results. I think China, they have also a very high coverage rate, especially in Shanghai, Beijing. But the HB and mother screening, some of them, they are not free. I'm not sure if this data are correct or not. Please correct me if my data is wrong. This data is questionnaire surveyed among all the, mainly on the pediatric hepatologists in each country. So the prevention of the hepatitis B by WHO, they recommend all the infants to receive HBV vaccine as soon as possible after birth, especially 24 hours, so that's the birth dose, and should be followed by 2 or 3 doses of hepatitis B vaccine to complete the primary prevention. So in the year of 2013, 93 member states have introduced the birth dose. 183, they implement hepatitis B vaccine as a part of their EPI, and 81% received the complete 3 doses of vaccine. So this is in the year of 2011. You can see that most of the countries, they do include the hepatitis B vaccines in infants, but there are some well-developed countries, they still not include the hepatitis B vaccines in their EPI program. For example, Japan. But to my knowledge, my Japanese colleague, Professor Fujisawa, told me that they are going to do this in the very, very near future. And on the other hand, for the Scandinavia and the UK, I think because they are, we just mentioned that this is our lower endemic regions. So maybe there is still some way to go, and maybe they are not in an emergent or urgent need to implement this kind of vaccination programs. Anyway, in the WHO Western Pacific regions, they set a year ago, they set the goal for the vaccine-preventable disease. The definition of the goal is less than 1%. I mean, in terms of hepatitis B, they want to set the below 1% of surface antigen in children less than 5-year-old. So we need to have a good vaccine efficacy. Yes, you can see that if the children born to the E antigen positive mother, it's not about 10%. If you don't give them, it's about 90%. So it's decreased about 1/10. And have we done a good job? I just told you that after the implementation of the universal vaccination for 30 years, the carrier rate decreased from about 10% to about 0.5%. I think theoretically, if the E antigen pregnant mothers in Taiwan, about 5% of all the pregnant mothers, they are E antigen positive. And the vaccine failure rate, that means the vaccine efficacy is about 10%. So theoretically, we will have a 0.5%. So I think right now, we have already reached the theoretical values. But it's not, what we really want is to achieve the eradication of hepatitis B, not only the 0.5%. So what's the possible causes of vaccine failures? I think mother factor is very important. We have already investigated those who still become carriers even under the accurate vaccine coverage. And we found that most of them, actually maybe 90% of them, actually their mothers are positive. So after the vaccination era, still the mother is the most important factors. Here is the data. We show that the higher the mother's viremia, the more likely the baby will get infected, even under the vaccination coverage. And so if the mother's viremia is 10 to the 7th power, it's about 9%. If the mother's viremia is 10 to the 8th power, it's about 18%. So the higher the possible. So what we should do is to intervene the mothers during their pregnancy. Maybe we should give them some, like category B, this kind of nucleoside analog, like TDF, lamivudine, or telvivudine. Here is some data. They did show that it will decrease the transmission. So, and the other thing is microbiota, which is a very hot topic right now. And we just show that if you give the mice some antibiotics, the surface antigen will clear. The surface antigen will clear less as compared with those without. So it seems that the microbiota in the infant maybe because we suppose that the infant has a less microbiota, and that may be one of the reasons that the baby will tolerate hepatitis B. This is a field of open study. I think we should give some more study and put some effort in this field. The next slide, I would like to show you that about, in short, we can say that about at the age of 10, about 50% of them, they will lose their antibody, anti-HBs. But actually, we have demonstrated that even after 15 years, although they lost their anti-HBs antibody, but the memory cell is still there. But for the university students who may be more than 20 years old, it's some of them actually, they may really lose their memory. But you can see that after an adequate boost dose, almost all of them can regain an adequate titer of antibody. So the vaccine booster consideration, here I would like to cite today's chairman, Professor Chen's comment. He comments that the no increase of acute hepatitis B in adolescents vaccinated 20 years ago in early infancy. This we have already shown that. And preventing acute hepatitis B infection in adolescent adults will become a higher public health priority only after chronic hepatitis B infection are successfully controlled. So right now, universal booster is not an urgency, but it is necessary for immunocompromised hosts. So here is the recommendation for hepatitis B vaccine, routine for infants and high-risk group. The other thing we would like to do is post-vaccination testing. We should do that about at the age of 9 to 18 months. That is after you complete the 3 doses of HBV vaccines. If the baby is negative, surface antigen negative, and with anti-HBs level, with adequate anti-HBs level, they should need no further medical management. If their antibody level is not enough, they should be revaccinated. But if they are surface antigen positive, they should receive the appropriate follow-up. So I think there are 3 ways to eradicate HBV infection. The first one is to screen the pregnant women and perinatal transmission. And the second one, because, of course, the neonatal vaccination, HB plus vaccine. And general preventive measures like wash your hand, practice safe sex with all the partners, something like that. And finally, we have to screen the high-risk population and register the carriers. Once we have once they are indicated for treatment, we should treat them as early as possible to prevent the final drastic consequences like cirrhosis and hepatoma. Thank you so much for your attention. Thank you.
Thank you, Dr. Ni, for telling us about the primary prevention of hepatitis B, especially on hepatitis B vaccination. His talk is now open for questions and comments.
Is there any disease progression by the
vaccine failure cases?
Yeah.
Okay, so your question is, if the patient is a case of vaccine failure, will the disease progression faster or become more severe than the regular one? I think this is very important questions. Indeed, we found that some of the hepatoma cases, maybe you are right.
Yeah.
But for the others, up to now, we didn't, because it's rare to see pediatric patients with cirrhosis. So I think up to now, right now we are investigating these cases. But up to now, we didn't have the conclusion that they will become much severe than their control group, than their counterpart.
Thank you.
Yeah, sorry.
Microphone 1, please.
I would like to ask, you have quite a high prevalence of hepatitis, virus hepatitis in your country. In Lithuania, we have just less than 2% and quite high prevalence of vaccination. But as a result of that, we have very big resistance of patients. They don't want to be vaccinated. Do you meet such problem in your country,
Yes.
anti-vaccine actions?
Yeah, this is a very good question, a very important question. In Taiwan, if the children want to go to the school, when they are enrolled into the primary school at the age of 6, all the school will check their registration, the vaccination registration card. If you didn't receive a vaccination, you will be, you still can go to school, but you will be urged to receive the booster vaccine or catch-up vaccines. The school nurse will continue to contact the parents and to urge them to receive the booster vaccine or catch-up vaccines. So this is our public health policies. And it seems no big problem, no big issue in Taiwan. But I know there are some rumors that hepatitis B vaccines may cause autism or something like that. I think we should do more to put more effort on the parent education and the social education. This is very important, yes.
Thank you for the answer.
Number 4, and then number 2.
Yeah. Sam So from Stanford University. Just a point of information, as of this year, antenatal HepB testing and HBsAg is free in China.
Okay.
But they they currently don't cover for post-vaccination serologic testing.
Yes.
But we're actually conducting a pilot program in Gansu province, which will provide post-vaccination serologic testing.
Okay, I think this is wonderful news. Yeah.
Jeff?
The residual risk to infants born to mothers with high levels of viremia of transmission despite vaccination. The WHO did not issue a recommendation for third trimester
Yes.
antiviral treatment. Do you think that's correct? What's your policy in Taiwan for managing highly viremic mothers? And what implications does this have for low-income countries? Because you'd have to do DNA testing to determine the level of viremia to implement that policy. I just wondered what you did in Taiwan.
Right now in Taiwan, we are still in the clinical trial phase. We have already published the papers, but it's still not become forming the a policy. It's still not required. But more and more mothers, they would like to do this because all these medicines, they are category B. And I think because if the mother is a carrier, under our current policy, insurance policy, I mean, they can receive one test for HBV DNA, so it's okay. So I would like to recommend that all the mothers receive, if you have already know that they are surface antigen positive, you should receive the HBV DNA, especially real-time PCR, to determine your viral load. And I think the cutoff point may be set at 10 to the 7th or 10 to the 6th power. And if you are fit the criteria, you should start to receive the analog, antiviral analog, and from the last trimester up to postpartum, 1 month postpartum. And I think we also published the result in our paper, and we show that almost no adverse effects for this subject.
Okay, last question from Bob Gish.
Thank you. There is a large number of childbirth events that take place in communities where there's no refrigeration. Vaccines require a cold chain. Are we having new vaccines developed that don't require refrigeration, that can be administered by midwives, helots in the Philippines, et cetera?
To my knowledge, there is no, but I think my Israel colleagues, Dr. Shuva, maybe he knows that he is developing some new vaccines.